Okay, we are live. So, hello everyone, and welcome to the second International Osteocom live event that we are hosting here on Facebook together with IAO, the Italian Academy of Osseointegration. I am Mattia, and I'm part of the Osteocom team. You might already know our platform, osteocom.me. It's an e-learning dental platform that has the aim to bring learning and innovation together, and to create some video courses with a unique educational program that we developed together with some of the most respected key opinion leader in the dental community that directly cooperate with us in the creation of these content that you can find on the Osteocom platform, osteocom.me. So I'm really glad to see that a lot of you actually decided to keep on following our live event, and actually that decided to come back today because we started a case discussion last week, but unfortunately due to some technical problem and technical issue, we were forced to stop the live streaming. So together with the authors, of course, we decided to give the chance to everybody to see the amazing outcome of the case that was presented during the discussion. And so today we will host the discussion with three of those key opinion leaders that already cooperate with Osteocom, and so we are very, very happy and very glad, honored to bring you a discussion with Professor Giovanni Zucchelli, Dr. Iñaki Gamborena, Professor Josè Nart, and they will be moderated by Dr. Alberto Pispero. I'm happy also to see that new users are coming, new people are connecting right now. So before going directly to the discussion and to continue the discussion, I'd like to steal two more minutes to talk about a solidarity initiative that we activated on the platform of Osteocom. It is called Digital Solidarity, and it is supported. This initiative is supported and promoted by the Italian Ministry of Innovation, Technology, and Digitalization. Basically, we thought that our users, the Osteocom community, but also the world dental community, should have the chance to turn this period of time into an opportunity to develop their own professional skills and to upgrade their own professional skills. So we decided to take out some video lessons from our best video courses and to give those lessons for free. Basically, you can get the access directly from the platform, and you can retrieve the lessons directly from osteocom.me. My colleagues in Osteocom will share the link to the Digital Solidarity Initiative page on the platform, so you can reach that part of our site, and you can put those lessons into you can add those lessons to your personal library on Osteocom, or otherwise you can just go on osteocom.me and choose Digital Solidarity from the categories menu. Of course, I would like also to point out the fact that those lessons that you are retrieving for free, they will be yours forever. So you will be able to have them forever in your personal library, in your account on Osteocom. You can watch them anytime you wish. So, okay, I think that we are almost ready to start. So just two last things that I would like to remind, ciao Alberto, that I would like to remind to the people that are watching us right now is that they can interact with the speakers, with the authors, by typing their own personal questions to into the comments to the live streaming, and we will bring those questions to the author so they can give an answer live. And another thing that is quite important is that this content, as the previous one, will be recorded, so the people can rewatch it every time they wish. I suggest them to share it on their personal Facebook account page, so they will find that. So they will find it there anytime they want, so they can rewatch it every time they want. And of course, they can find it in the video section of the International Osteocom page. So I leave the floor to you. You can go on with the presentation. Hopefully this time we will have more luck for our live streaming. And so, what to say? Enjoy the discussion and enjoy the discussion and enjoy the case.
Thank you, Mattia. Thank you. It was a success the last time.
Yes,
so
yes, sure.
It's not a problem. Also, if sometimes stops, but now we're back here, so we can continue.
Yeah. I'm very happy to see that a lot of people actually decided to come back, because anyway, the case was amazing. So I think that everybody is wishing to see the outcome.
The case was amazing. Also, the discussion between the three speakers was amazing. So just two things about me. I'm Alberto Pispero, Secretary of the Italian Academy of Osseointegration. That is a big Italian society, or scientific society of osseointegration, of implantology and oral surgery. And so we are back. We are here for the second match of the big show of the last Friday. And we want to discuss what happened the last time. I remember you also only that you can see, if you want, all the contents of our website, the video contents of lecture, of our guest, of our discussion that are recorded. If you go to the www.iao-online.com, as you can see here, we are sharing now the page of our society. You can go to the top of the page and subscribe on IAO Prime Video, so you can have the free access in this period to our contents of the website. So here we are. We can invite here Professor Giovanni Zucchelli, Josè Nart, and Iñaki Gamborena. Do you remember the last picture of the last online discussion? Now we have to continue for this big show, and this is the time for the speakers to raise up. Professor Giovanni Zucchelli, Iñaki Gamborena, and Josè Nart. Alessandro, we are ready. Hello, Professor. Iñaki.
Hello, how are you?
Nice
to be here again.
Ciao, hello everyone.
Hello.
So we can share your screen, so you can show us the picture of, or last picture of the Friday.
Wait a second. So this was the last picture. We were discussing last time to maintain or take out the implant. So the good points, a few good points were raised. One was from Giovanni, that he will do some orthodontics, distal upright, just to allow more space to then in a second time do the soft tissue advancement with some vertical releasing incision. I would like to share with you where we started and what was accomplished. This was accomplished with 2 connective tissue grafts, and we'll go in a second how I did it, and 2 orthodontic movements, one distal upright and one extrusion. And I think what is important about this case is to discuss the timing and the sequencing, because it doesn't really follow what all of us have learned. For me, the best, every time I have an interproximal problem, the first thing that I'm thinking of is about my orthodontist, because he's the best surgeon on earth that can put back my papilla where it belongs. So I would like to discuss a little bit the treatment planning, because the beauty of this case is how you plan it in your head, how you execute it, in order to be as close to the 99.9% of result. So I'd like to discuss a little bit the sequencing and the treatment planning that was done in this case. And I would like to share also, ask some questions to Giovanni and José. What I did in this case, I did first a connective tissue graft, just to cover my implant without doing any orthodontics. I think a good point was raised by Giovanni, that he would maybe do orthodontics just to move laterally, the lateral incisor, in order to improve the distance between the root and the implant, and then in a second stage do the second connective tissue graft in order to graft as much as possible crystally based on how much he was able to create on the first surgery. And I think this is a good point. I agree with that, that maybe I will never do extrusion before doing the connective tissue graft, because if you do that and you fail surgically with your graft, you have lost all the opportunity of recapturing that papilla. So it goes totally against from what we have learned. And why I do that is because I failed surgically, and then I lost all my possibilities of using my orthodontist to recapture the bone and the papilla. So I don't think it's a great idea. You can maybe do orthodontics horizontally in order to do your connective tissue graft, and once you have excel or you have succeeded with your connective tissue graft, then you do the extrusion. But in any way, I would do the orthodontist before doing the connective tissue. Besides that, the more you do the connective tissue or your surgery before, the orthodontics, this is what I did it. I did before my first connective tissue graft in order to overcome that. Because once you do the movement with orthodontics, the density of the tissue is different. So the pull of the bone, the pull of that tissue that you have already grafted is much better. And you will see it on the case as we go along. Another issue that is common and really well described in the literature, and as Giovanni described, is to put a healing abutment to just hike the soft tissue coronally as much as possible. There are few tendencies. I think Giovanni doesn't do it that way. But there are many clinicians that place a healing abutment and waits for the soft tissue to pretty much cover it. For me, this is the worst alternative that I have been involved with, because especially with this type of implant, if you ever cover with a cover screw, be sure about the type of connection you have. I will never dare to do it on an external hex or a poor internal hex, where here is a select, where you have a lot of filtration, is not a sealed connection. If you leave the soft tissue be covered on top, I don't like it, because you have a fistula. That fistula has a chamber of epithelium, and usually if you do your connective tissue and you don't take into consideration removing that epithelium, you can have a fistula as we go along. So for me, I rather leave, I never wait for that tissue to collapse, because the bigger the hole, the bigger the space, the more I use the entrance of my connective tissue into the tunnel through the implant head. Here I have a 5 millimeter, and I will explain in a moment, but for me, I keep the provisional the way that it is until the day of the surgery. Obviously, the patient has been through a lot of cleaning aspect. Let me go through all the process, all the thinking process, and then we can discuss it once we finish the sequencing, just to have different point of views so we all learn. But for me, I wouldn't use a cover screw here. I rather use a slim abutment. The slim abutment is a connection, is a really straight, is really narrow healing abutment that allows you to graft crestally as much as you can, and having a connection to the outside world. This also has different issues and different problems, so there is not the best solution always. So we do the connective tissue first graft, and then once I have succeeded, I reevaluate around 3 months later, and I'm going to ask my orthodontist to upright. Then we'll discuss with the orthodontist that when you upright a tooth, one of the best ideas is if he can intrude. Usually they intrude a little bit. In this way, intruding the tooth will allow to have a flatter soft tissue anatomy, which will be easier also for grafting and not having to advance so much the flap coronally. So once he opens the space, sometimes we do some stripping on the mesial aspect of the canine, or distal. It depends the need of the space, but I rather not touch my canine because teeth move around during the orthodontics. And then once the space is ideal for me, then I will try to improve the interproximal soft tissue in order to overcome the vertical defect that is in that area. Before doing the extrusion, I always provide my orthodontist with a provisional restoration. So he uses the provisional restoration as an anchorage just to create a really slow extrusion of the tooth in order to level the interproximal tissue to the contralateral lateral and finish the case. So I think I will, at this point, maybe stop the conversation. So if you want to add something about what I said that maybe you like, you dislike, you will do it differently, it will be a great time just to discuss it.
I personally think that it would be better to show us how you did the first surgery, okay, and then the second surgery, and then we will discuss a lot, I think. Okay. We will stay here up to 12 o'clock in the night.
Okay, so let's go ahead and show that. So the problem here is the distal papilla.
This is the first one, yes?
This is the first one, first connective tissue. You can see it on the left. It's tunneled, okay? So I don't like to use vertical releasing incisions. So basically, the papilla that are cutted are distal to the lateral, distal to the canine, that goes all the way up to the first premolar. This is partial thickness flap, okay? It allows me to go from the lateral.
Yeah, but what about the papilla between the implant and the lateral? This was open.
Wait, I haven't get to that yet, okay?
Sorry.
So I go, the papillas are elevated. That means I do a vertical incision all the way down to the bone on the adjacent tooth. And what is E means elevated papilla. Why the difference between the left side and the right side is that on the number 21 side, I don't have to bring so much my coronally my papillas, because that's why I elevate them, I don't cut them. And then on the papilla that has to be elevated, I have a circular incision, and then I go from the side in order to elevate my papilla buccopalatally. Okay. This is full thickness. How I do the full thickness is because I'm coming from the side here. That's why I open one side all the way back, just to go from the side. Everything is partial thickness, and then above on the center is full thickness on top of the implant to get as much thickness as possible, okay? So the idea behind is that everything is partial thickness on the other side, just to have a better, the difficulty here, as everybody can understand, is to elevate that thin tissue here without breaking it, okay? I like to have this hole. Why? Because this hole will allow me to insert all this piece of tissue. Remember that I have a hole just below it. And what I want is through this hole or either from the flap from the side, but in this way, I want to move the flap forward and coronal. That's why I elevate all that flap from distal towards the medial to bring and cover as much as possible this tissue that is coming from the tuberosity. The idea is first I go from the outside, get into my tunnel, and get my soft tissue on the buccal and on the palatal, just to insert through this through the hole of my implant access to place my connective tissue exactly where I want. Okay, so I suture it buccally, palatally, and then what I do is I make a cross and insert my slim healing abutment. Okay, so this is pretty much a little bit roughly all the explanations, and this is the, instead of having a cover screw, I rather have this because the connection, I never had any type of fistulas whatsoever doing this technique. I try to bring all the tissue. For me, the palatal aspect is untouchable. I don't do any pedicle grafts, anything like that. The thicker my palate, the happier I am. You know, I try to avoid pedicle grafts because then you will never have the same height of papillas either. So I don't have as such nice results as I do with crystal connective tissue grafts. So this is the 2 weeks healing. You can see that the tooth is resting on the 5 millimeter high healing abutment. And you can see that I have now a recession on the buccal aspect. And this is 3 months on the right, is 3 months later. We are ready to, now we have a better soft tissue. Now I have a situation where I'm gonna create a diastema. The tooth in composite is bonded to the adjacent tooth. And I create a diastema, so the orthodontist here, Itamar from Barcelona, is going to upright, intruding a little bit the root. So intruding will flatten the interproximal papilla a little bit and will be easier for me to overcome the second connective tissue graft. So you can see the work done by Itamar in Barcelona. And then on top, you can see where we started and then where we finish. So pretty much we have 1.5 millimeter. So you can see that sequencing the orthodontics at the same time that we are doing the periodontal surgery, really you can bring the papilla exactly to where you want it. If you look at the papers that have suggest to do the orthodontics before doing the surgery, look at the final result. It will never be fair. It will never be perfect unless you go back and do again another orthodontics and rescallop the buccal soft tissue. So now we are phasing to decide the second connective tissue graft. You can see that we're having an ideal situation. The buccal aspect is already almost coronal on my implant to where I want to copy, but I want to cover the lateral incisor and do my second stage. The second stage here, the second connective tissue graft in this case is tricky, really tricky, because you have the...
Also, the first one was tricky, in my opinion.
Yes, it's tricky, but this one is even more tricky because,
oh my God.
Because if you take the healing abutment off, you break the crestal tissue. So the problem here is I don't want to remove the healing abutment. You can create now, everybody can can fix it with vertical incisions. We are in a situation that is really easy now to fix it up because we have dense connective tissue. We know it's reliable. And then this one is tricky because I don't want to remove the heel abutment. So what is it? Wait. Basically, I do something that I call the trouser. So it's a piece of tissue. The mesiodistal space is already measured. This is the belly. This is the legs. It can be a short pant also. And then the thicker tissue is always on the crest. The smaller tissue is on the palatal. Because the more tissue you put on the palatal, the more difficult it is to close the flap if you have an open flap. So crestal incision is always important. Here we're not going to do a crestal incision, and we're going to cut the tip just to rotate that piece of tissue on top of the lateral incisor because we have the recession. So this is what it looks once we have finished. You can see that the bigger quantity of soft tissue has been placed in between the thickest tissue on the crest. And you can see that the more tissue is pulled in between the implant and the tooth, you can see that the tissue opens up, okay? And you will see why it opens up. So this is the trouser, and then we made a cut here, and this piece here is cut it half the way, and is rotated towards the buccal. That's why this part is open in order to bring as much tissue as possible in this area and to bring it as vertically as possible. Before placing all those cuts are done outside of the flap before inserting the connective tissue where I want. But the soft tissue is already anchored from these parts. Is anchored from the palatal aspect. You can see where I have a suture here, a suture here, a suture here that goes around, a suture here that goes around the tooth. So it's pulling my connective tissue against the tooth. So you can see the suture. And another suture that is going to go against the root of the lateral incisor below the soft tissue, and is anchored also with a sling suture. You can see the blue is for the...
I don't know if there's somebody that's saying that they cannot see your pointer. Is it possible to see the pointer?
Yeah, wait a second. Let me see if I can...
Alberto!
Wait. I don't know why.
You can ask of your presentation, so you can show only one slide without the presentation mode.
Wait. I'm just pulling this. Let's see if it works. Wait, go back. Okay, now it's working. Is it working now?
No, we can't see anything now. So you can press ask on your presentation.
Okay.
Ask just okay. You can show only one slide.
Okay, yeah, sure. Wait.
Okay. Zoom. One more. Go on the top, on the left. Yes. As you can see here, visualization on the top on the left, just close to 200. On the other side.
Top on the left.
On the left.
Yeah. Okay. Share, I mean.
Okay. Visualization. You can see there. You can change how to show the picture. You can see on your screen, on the keynote.
On the keynote?
On the keynote, yeah, on the left.
Okay, here?
Just close to 200. On the left, there is visualization.
Yeah, wait. Okay, got you.
Okay. Visualization. No. On the left. Visualization. Okay. Click over there.
Okay.
Okay. Perfect.
You can see there.
Better now.
Okay. So now the one is here. I don't want to break this tissue. Everything is full thickness again because I want to increase as much tissue as possible. Wait a second. Why is not working?
Wait.
Now it's working.
It's working.
It's working?
Yeah. We can see.
Okay.
Okay.
We can see the pointer.
We can see the pointer now.
Yeah, but you cannot see the layering.
No, the layer, no. You have to explain with the pointer and then we can follow you.
Okay. So what I do is you can see this is after I finished. So before I insert my connective tissue inside, I have my one cut in the middle in order to go from the side. This is difficult. So one leg will go this way. The thicker leg of my trouser will be in between the tooth and my healing abutment. And the buccal aspect, I don't need so much on the buccal. It will be rotated and grafting at the same time with one piece, the buccal aspect of the tooth. So you can see that before I insert into my tunnel the connective tissue, I already have been suturing my connective tissue from 4 sides. Here, 1, 2, 3, 4, and then on the buccal. Okay. And this is how you do it. You have the. I will go with the presentation so you can see it a little bit better. Then I cut. That's why the left side is movable. So it's not a partial thickness above mucogingival line, just to bring the soft tissue as much as forward as possible. I cut the buccal aspect just to bring towards the side that I need the most. And I have 4, I don't know why it's going. I have 4 sutures, one here, one here. I don't see it. I don't know why. Let me back again. Okay.
So if you go to the keynote preferences, okay.
Wait. I think I have it. Wait a second. Let's see the white pictures. The white on top. You can see that I have on the palatal 2, on the interproximal 2 that go around the connective tissue. The white is PTFE in order to secure the position, and then I close the flap on top of the tooth. And this is how it's done. So this is 3 months after the healing. You can see now we're going to place the provisional restoration. The tricky part is now to take out the slim healing abutment. And you can see we make an incision on the mesial aspect where we have the thickest tissue, not on the papilla I want to improve, And then I try to pull it from the side in order to come up. So the terrain that I have it in here is minimal, just on the mesial, little on the distal. I was lucky. And then I finish the case. Then the orthodontist makes the final extrusion, and then we stabilize the case for 8 months before I go ahead and finish the case. So these are the different stages of the same implant from day first to final. First connective tissue graft, second connective tissue graft, extrusion, upright, and extrusion. And this is what we got. And this is the I could have done a screw retain, but the incisal edge was too weak. So we used 2 cords, one on the buccal, one on the palatal, totally independent, which is packed on the adjacent teeth in order to control how much soft tissue removal, how much cement removal we are going to take out. This is the day that she left. We did we did a composite the same day on the mesial aspect. The lateral incisor is just recontoured due to the extrusion. No veneers, no nothing. Composite on the mesial aspect of number 21, a little bit of rescalloping. This is an iPhone video with slow motion, which is not good because you lower the resolution a lot. It took me 1.5 years to see her back. This is 1.5 years later. She sees like that, and then we just retouched a little bit the soft tissue and finalized the case. This is the papilla consistency. We always splint adjacent teeth to an implant. I hate seeing extrusions, even though you have a perfect occlusion. Teeth don't like implants, and this is one of the biggest problems we face in our practice, and this is the final case. So many people ask me about so you can follow me on Instagram. Many people ask me about the smile, and I forgot to put it, the smile line. So this is
the smile line is always very high. That's the rule of this webinar.
Yeah.
It doesn't exist a patient that don't show. Otherwise, we are speaking about nothing. So the patient's smile line is always very high.
Yes. So this is where she started, and you can imagine where she finished. So
yeah, that was wonderful.
Iñaki, terrific case, man. I think technically what you do is just unbelievable. It is very difficult to do partial thickness coming from so far.
Can you go back to the suture the side of the suture removal of the first surgery? Because I really want to understand a bit more.
Okay.
Yeah, I think, Iñaki, the audience is also questioning from where do you insert the graft in the first case and in the second one?
Okay.
Because look, can you show us also? I don't want to see Iñaki and José. I just want to see the surgeon.
So you want this picture? Which one you want?
No, that one of the suture removal.
Suture removal. I don't know if
after this, there was one after this, and this after this.
Okay, the suture removal. Wait.
Because since we don't have so many steps.
Yeah. I'm in private practice.
I am in private practice too. But people has to understand, because everybody is saying it's incredible, but I want to understand. Yes. And that's why most of the time I don't make tunnel, because most probably I'm not able to understand enough, because I don't see and I don't understand.
Yeah, it's true that doing a tunnel, you work in a totally different scenario. You have to make sure that.
Yeah, I think I have experience enough to understand.
I agree with you totally.
May I see the suture removal?
No, I don't have suture removal.
Yes, I have. I saw a picture. Can you go
forward?
Back? No, back.
Back. Okay.
Just one.
This is the day, the day of the surgery.
Okay, this is okay. That's perfect. May I see this at high magnification?
Yeah, sure.
So the whole screen.
Do you want to see this one?
This one, yes.
Okay.
Because this maybe tells us a bit more. Because what you have to tell me, if distal to the abutment, there is no graft exposure, yes or not?
No. It cannot be.
So you see how big was this graft and how incredible. So at least you have to tell us that the abutment was penetrating through the graft.
That's correct.
Or no?
Yes. That's correct.
Oh, yes. So there was a hole in the graft.
I put the graft. The graft goes first. I suture the graft coming from the outside into the tunnel. I go out through the middle of the access.
But when did you place the abutment? Did you place the abutment through the graft?
Through the graft. Once the graft when the graft has been sutured.
After being placed the graft, you get through both flap and, or let's say, hole and graft. Yes,
that's correct. This is the only way. So
that's the only way. So there was.
Look, I try to show that in this picture. You know, wait a second, and let me go through all the gizmos here.
Yeah. And
I go through the whole of the implant. So if you use
yes, I understand now. Now I understand.
And
so
then,
through this hole, you insert the old graft.
Yeah, and
the graft, then you perforated.
Yes, and then when I have it in place, where I like it, I perforate. I bring the tissue inside through this hole. Sometimes I do it from the side. If it's a lateral incisor, it's impossible. You will break and tear the hole, you know. But here is a 5 millimeter, you know. And then once I have everything where I want it, buccolingually sutured, then I make a cross. I make a cross until I'm able to fit my healing abutment into the implant, and I check it with an X-ray. Okay.
José.
Yeah.
Are you able to do it?
Yeah, of course you are able to do it. Of course. You can do it, and then you close. And then you close the hole. Closing the hole is nothing, you know.
Close the hole means pulling the tissue.
Yeah, he advances coronally.
Advance coronally, yes.
Yeah, I was telling Iñaki before, Giovanni, that going full thickness from so far, and then being able to raise all the crestal area without perforations and going even towards to the palate. Needs a lot of training or great hands. I mean, Iñaki does have them, but
yeah, this is the tricky part, the difficult one. We use ophthalmic blades from which is the blade is only 1 millimeter in width. We have been using those blades. They're American. They are ophthalmic blades, so you can do it's really small incisions on incredible places, you know. So. And then we elevate with really thin. All my tunnel instruments have been modified. The tunnel instrument that I use to elevate this papilla in between the teeth is less than 1 millimeter. You know, it's curved.
So this old graft was inserted through the hole of the implant.
That's correct. That's correct.
Yeah. And the distal papilla of the lateral was just used to help you to put in the right place.
That's correct. That's correct. The problem is I have to open the flap towards on the distal of the papilla. I want to hike up coronally because I want to close it. I want to be on top of it. So I have to cut the papilla between the lateral incisor and the canine in order for my my graft to move coronally. So the tension is always on the distal aspect of my on the vertical mattress suture between the lateral and the canine.
Iñaki,
yes.
How did you manage not to raise the flap or not to cut it in between the implant and the lateral incisor, because you didn't perform ortho before the first connective tissue? You did not see.
No, you did.
How did you do it?
I elevate all the interproximal soft tissue. I just elevate first the flap on the left.
Yeah, but you did ortho before to increase the papilla area, yes?
No.
First connective tissues without ortho.
Without
the first one, yes, sorry.
This is what
you...
You suggested to do maybe ortho before doing this first approach, which is also a really important question. You know, I will agree with you that you can do horizontally as much as you want orthodontics, but never do the extrusion. You know.
Yeah. Yeah.
I have to admit that most probably I would not be able to do this, because it's really, you know, from one point of view is that somebody say that you don't have to advance the flap coronally because there is tension, because there is disalignment of the mucosa, but all these aspects are present also in this picture. If you look at the occlusal picture, you see that the mucosal tissue was brought very, very palatally in the same way. Yes. So the problem of the advancement of the flap still remains. The big deal is how to be able to insert such a big graft, because it's really big graft through a very, very small hole. So I think this is really technically very, very demanding. And I think most probably people understood, because I was looking at the questions and everybody understood this, but for me it was not easy, not easy at all, really, because most probably I have a different way of thinking.
Yes, yes. But,
where did you harvest the graft? This one?
Tuberosity.
The first one, okay.
The first and the second one. So another issue to discuss is that many people like Giovanni tells me, well, you cannot have so much tissue. Well, the thing is that just kidding. I'm just kidding. The thing is that I always do stitching on the patient to see that if the patient is able to provide me the quantity of soft tissue I'm thinking of, you know. So that's why I do stitching. I measure it and I say, yeah, I think I have enough tissue just to really be able to do it in 2 or in 3 times. Even if I don't have enough and I have to go a 3rd time, I will take it from the palate or from the retromolar pad. So it depends, but it gives me already an idea of how much it can be done.
Iñaki and José, do you allow me to show you a case that was treated in a different way, but it was from some aspect, let's say, quite similar, just to discuss, because this is exactly what I would like to do during my years of presidency, so to see different approach to the same or very, very similar surgical or to very similar situation. I don't know if you can see it.
Wait a second, Giovanni, wait a second. An important point for me, every time I try to bring the flap so much palatally, okay, and cover an implant, because you're gonna use a cover screw. I don't think it's a good idea. I would like to ask you, is a good idea to leave a cover screw and see if the tissue covers it? Do you do this? This is my first question. And the second question is that something that I always do is try to de-epithelialize the surrounding of my palatal tissue, all the sulcus. So all the soft tissue that is coming from the buccal really has an interface with the palatal in order to improve that, okay? So yeah, go ahead and show your case and discuss it.
No, it was really something that get to my mind when I saw your cases, because from some aspect, can I share it?
Yeah, sure.
No, sure. I was asking, do you see it?
No.
That's why I was asking if they can share it.
Wait a second.
Alessandro is sleeping.
Yes,
Alberto
we are here. Now we can see.
You can see now?
Perfect. Yes, perfect.
You know, this from some aspect, it was not as difficult as yours, because there was already the papilla between the, let's say, the implant and the abutment and the lateral incisors, which was also lost in terms of papilla height. And if you look at the X-rays, you can see that there was a great loss of attachment and bone also in the lateral incisors. So there was really some loss of bone in the lateral incisor together with the loss of the papilla. But in this case, the lateral was already orthodontically moved. It's not true. I was lucky, because in this case, the lateral was exactly in the same situation your lateral was after orthodontic therapy. You understand what I mean? Yeah. And don't look the cone beam, because the material you see in the cone beam was really not bone, and most of this was unfortunately removed during the surgical procedure. I just want to tell you what I was telling you last time. You know, if you elevate the buccal flap Yes, you have to make 2 vertical release incision, but you can use the 2 papilla, the mesial and distal, as a, let's say, a platform, because you remove the epithelium from this papilla area, and this becomes a connective tissue platform onto which you can apply different layers of connective tissue. One, very, very small but thick, taken from the tuberosity, and more layers. And in the same time, you can also augment the buccal and the occlusal aspect. Now, the only trick is that your buccal flap is so free to be moved coronally and palatally to reach the palatal flap, not exactly the palatal flap, because you don't really need to achieve a very, very first intention wound healing into the palatal aspect, because even if the graft exposed into the palatal aspect, nothing happens aesthetically, but you have to cover 90% of the graft in the occlusal and in the buccal aspect in order to give blood supply to this graft. And obviously, the graft is left covered. But as you say, this is something that lasts only few months, because after a few months, what you can do, even if there is some epithelium, since you take an impression of the head of the implant, you can punch and rescue the head of the implant again by removing only the tissue mesially and distally. And so in the same way, you did maybe 1 surgery, 2 surgeries, this depends on the amount of tissue you have available from the palate, you can achieve a good outcome. But in this case, I think that the survival of the graft and the dimension of the graft, it's much more limited than what you took from the palate. And in my hands, I understand that by advancing the flap toward the palatal aspect, it's more easy to completely cover the connective tissue graft. So this is a different approach to a case that is very, very similar to yours, and you can see that the papilla is there despite the loss of attachment. It's still there. So if we go back to your case,
can I ask you a few questions?
Yeah,
because it's not clear to me. Can we go to the number 2?
Yes.
No, number 3. Wait. Number 2. Number 2. Okay. So on the, because
you make horizontal incision here.
Yeah. I understood. But on the far right, you have already placed a piece of tissue on top of your implant.
This is the same day. Yeah. This is a connective tissue graft taken from the tuberosity.
Yeah, but you suture it there.
Yeah. I sutured it, obviously.
Okay.
It's very easy because you can take the graft to the papilla, to the papilla, and this is suture. This white tissue that you can see it's amelogenin that is used on the lateral in order to try to improve the level of attachment.
Yes.
So this is the first.
Okay.
The first graft suture to the mesial and distal papilla. Okay. So this is something that everybody can do because you have the connective tissue coming from the desepithelialization, occlusal desepithelialization of the papilla.
Yes.
Then there is a second graft that is placed buccally to compensate the buccal lingual tissue loss.
Okay. So you suture it to the
connective tissue in the buccal aspect.
Okay.
No, yes, it's connective tissue. It's really not very. It's still connective tissue at the base of this papilla.
Okay.
From the buccal aspect, this case.
Yeah.
And the third one is placed occlusally and placed above the first one. That was that one of the tuberosity. So it's 3 different layers.
Okay.
And obviously this doesn't work if you don't cover it completely. But you have 1, 2, 3, 4 sutures, which allows the correct positioning of the graft. That's everything, something you can see. You can see where you're doing.
Can I see?
Now you have.
Can I see the next one, the suturing?
The new suturing of the flap?
No, the flap, yeah. The next one.
It's an advancement of the flap. You see the most palatal aspect of the graft is left uncovered because this is an area that aesthetically is not so critical. And then the flap advancement gives blood supply to the graft, but at the same time, by placing a distal vertical release incision to the lateral and a distal vertical release incision to the central, you can also achieve coverage of these 2 teeth because the flap is advanced in 1 surgical setting only.
So I have a question. How long did you wait from the first. Can you go forward?
The forward, you mean the punch?
Yes. Yeah, the punch. Can we go?
This is about 8 months later.
8 months.
Or maybe more. Yeah.
Okay.
You have to wait a lot of time. And so even if you, as you say, there is some reepithelialization above the head of the implant, by punching it, you remove the old tissue and reach again the head of the implant.
So
because
how long?
this surgical stand was prepared on the impression that I took the first day I met the patient of the head of the patient. So I have the precise position of the head of the implant, and so this is very precise. I don't touch the papilla, but only make the punch in the middle. And then with the temporary crown, you are a master of this. You condition the tissue, etc., etc., etc.
So how long does the tissue take on your graft on average to have that creeping effect of interproximal?
Oh, 8 months, 9 months.
Yeah.
No, that's maturation phase.
Maturation
6 months, 8 months, and then there is the conditioning phase with the temporary crown, which also lasts 5-6 months.
Basically, I agree that it takes 9 months after the final delivery of the crown.
But I was just discussing surgically the difference in the surgical procedure, because the difficult for me is to understand where is the graft positioning, how you can handle with this big graft, because my graft is very small, while your graft is very big that has to be inserted in a tissue that remains firm. And so it's very difficult, in my opinion, to be able to handle if you don't see. And maybe it's really a question of instrument. And I think that it would be important to understand how this instrument works in the whole in order to understand how to do it.
Yeah, the problem also is that mine was a central incisor. Yeah, it's the same tooth. Yeah.
Yeah, same tooth.
Giovanni, did you do anything?
Different approach.
With this stage 2 tissue?
Sorry?
Did you do anything with this tissue that you removed with the circular blade?
No, I sell it.
Okay. And I hadn't seen you leaving the graft exposed anytime, but you showed it.
Yeah, that's only in the very, very palatal aspect. If you have to force too much, since it's only one graft that is occlusally and buccally, if you have to cover also the palatal aspect, doesn't make so much sense, because it doesn't have an aesthetic impact, and most of this has to remove with a punch. So you can also leave a small part of this exposed. This is very, very few cases that I leave it exposed. You are perfectly right. But I wanted just to tell you that by advancing the flap, yes, you advance the flap, you can reach also the palatal aspect and give coverage to 90% of the connective tissue graft that will heal. And in the same time, by advancing the flap, you can also improve the situation of the two adjacent teeth. And it's a two different approach. But I want that it's very, very clear that most probably we can achieve the same outcome, or most probably I have to tell you that your outcome was much better than mine, but because most probably you did also orthodontic. Because if I did some orthodontic extrusion of the lateral, most probably I would have achieved the same papilla of yours. And so it's so important what you said, that the best surgery for the papilla is the orthodontist.
But you have to do it at the end of the procedure.
Yeah.
Not like we have learned it at the beginning.
No doubt.
Because if you do the extrusion, you open the flap.
No doubt.
Nothing.
No doubt. And you need a lot of thickness of tissue in order to take advantages from the extrusion at the level of the soft tissue mainly also.
I have a question for you, Giovanni, just to learn, because...
No, we all learn. That's why it's so nice, this case discussion, because we have different approach for the same cases.
But for example, what I see that it's amazing, because we have to move interproximally the flap quite a bit palatally. So I can see you were not able to close it perfectly, so you left.
You know why? I could have done it, but there was not enough gingival recession on the central and on the lateral. And so I would have made a submarginal incision at the two adjacent teeth to reach the palatal aspect. I didn't want to lose keratinized tissue. That's why I didn't reach.
So that is why I'm asking this question. Would you have change the verticals, maybe in order to avoid the rescalloping of the gingiva and losing the gingiva on the teeth? Would you have maybe brought the vertical incision a little bit closer, not as wide, in order to be able to penetrate interproximally towards the palatal more? Or you will still...
But you cannot make in one surgery. You have to do, you cannot cover the lateral if you make a vertical release incision only in the dental side. It's very easy to reach the palatal aspect, but you cannot improve the adjacent teeth. So yeah, something that you have to select. But I think that leaving some minor amount of graft exposed in the palatal aspect is not such a big issue.
We know that you can leave around 10% of the...
Yeah, that's less than 10%. It was covered 90%.
Iñaki and Giovanni, for those that are afraid of... you see displacing the mucogingival junction when we do coronally advanced flaps. It was very nice to see at Iñaki's case that at 3 months, when he saw the patient again, the mucogingival junction was already replaced at its position. So,
it depends on the...
No drama.
I think that what you said is so important, because what we do is to advance the alveolar mucosa with no muscles, and so the mucogingival junction realign quite quickly. It changed from one patient to the other, but we are not advancing the whole muscles. That's the difference between advancing the flap or advancing the fornix.
This is something that we have learned, the whole community, from you. I remember the first study we published in this area without releasing the muscle. It was a real nightmare. I mean, I don't know how we got the results we got, because pulling everything up, it's just impossible. So cutting the muscle out is a need.
So, José, what would you do in such a case?
So I think we've learned several things here. One, that ortho is key, and it has to be performed at the end. Once you get non-inflamed, dense connective tissue there to take advantage of. You know that I like to tunnel, but Giovanni, we can go to the first picture again.
Oh my God. Yes, sorry. What should I have done? My case, you mean?
Yes. Alessandro, can you show us the screen of Giovanni?
No, because I made a mistake and I removed it. Just wait for a second.
Okay.
And how can I share it? Okay, now I remember. Share screen.
Iñaki, there are a lot of questions about your second graft. So maybe we can better explain after, if you can.
No, you can make questions now, because I don't know how long it takes me.
Okay, the people about the treasure, in which way do you put the CTG on the to achieve these results? If you can explain exactly the way in which you did the graft.
Well,
Iñaki, they need to know the trouser technique.
I'm in pajama.
Sure. Show us the pajama technique so we can explain it better.
Well, here the second I don't have a cover screw. So it's a problem, So I'm bringing the tissue from the side into the crestal. So
try again, Giovanni.
The entrance of the tunnel now is not the whole of my implant. To elevate the papilla to go from the side into, so in order to pull my tissue inside the tunnel, I suture it.
Okay.
And why I have to trouser is because I want to go around my healing abutment, from one side and the other. It's really difficult. But
can you show us your screen so we can share with the audience so what you said now?
Giovanni, I also had another question for you. When you remove the graft from the tuberosity, do you take it subepithelially, or do you remove the epithelium afterwards?
Wait, we are talking about the pajama now.
The pajama is coming. Okay, so
we want the full screen pajama. Okay. If we can also try to have a pointer so you can explain us exactly.
Do you see the?
No. You can try.
No?
If you click on the apple on top of your screen on the left, and then you could do preference of system preference.
Okay.
Ok, Ale, ce l'ho fatta, però
Okay.
non vedo più voi.
So what do I do?
You can wait a second. Okay, keynote preference.
Yes.
Okay, keynote preference, and then you can show interaction pointer if you use the mouse or trackpad.
Keynote.
Just close to the Apple keynote, and then interaction. Show us pointer if you use mouse or trackpad. You have to click on presentation.
Okay. Presentation. Yes.
And then show us pointer if you use mouse or trackpad. In the second block, interaction.
Where do you see interaction?
There is general and then presentation. You click presentation and the interaction. Okay. And 1 or 2.
So visualization here on top? No.
No. You have to click on the keynote, just close to the apple.
Yes.
Then keynote, and then preference.
Yes.
And then go to where you see presentation, you see generals, presentation, go to presentation, and then 1, 2, 3, 4, 5 line, you click on show pointer. Okay, it's not a problem now. We can try to explain in a different way. Okay, don't worry, Iñaki.
Okay.
Okay, try to...
Anyhow,
See?
do you see my pointer here now?
No, we can see your pointer because now we are sharing the presentation of Giovanni, and then you can share your presentation.
Okay.
Yeah, let me answer. Giovanni, it is absolutely true that if I try to approach this case with a tunnel, you see the papilla height is very limited. So I have trouble to cover the roots of the central and the lateral with a tunnel approach. This is very clear, I mean, to see. So I would ask the help of ortho to extrude, but this patient has had ortho already and has attachment loss. So yes, your approach of increasing, placing the graft on the crestal area makes a lot of sense. And this becomes harder with a tunnel. I mean, Iñaki does it, but I think it's harder technically than raising the papillas or cutting the papillas.
This is the... Sorry.
No, go ahead.
The same technique you use if you don't have the implant. When you want to augment the dentulous site only, it's very easy or much easier to use the whole dentulous site, which is partially desepithelialized, to apply connective tissue graft above, and then your flap goes lingually to cover it. And this is I think, the only way we have to improve papilla height surgically, because you have to put the graft occlusally. Otherwise...
I think the most important is to show people that you don't cut the papilla, you de-epithelialize the papilla in order to use it as a tentin. Because the common mistake around the world is that the way that you treat surgically an implant site, you don't do it the same than with teeth. So normally you cut the papilla in between the implant and the tooth, and then this is the disaster. Here what you do is you de-epithelialize, maintaining the papilla, so you can bring the soft tissue on top of it. I
always do this.
Yeah, but this is not normal. Normally everybody cuts the papilla, and cutting the papilla you will lose height.
Posso avere la mia presentazione?
Yeah, Iñaki,
can you
right.
see now?
Thickness is totally maintained, absolutely maintained.
You see here, this papilla here.
Yeah.
Only the external layer,
yes,
which contains solid epithelium and connective tissue, is removed. It's elevated.
That's correct.
All connective tissue, which is connected to the palatal tissue, is left, and only remove the epithelium to apply the connective tissue graft above. So it's only a very, very split thickness papilla, which is at the buccal aspect elevated.
But this is why you succeeded. If you you elevated, like you elevate a normal, you cut and elevate the papilla, you are dead. You will never be able to go back and improve the height. You know.
No, that's for sure. So this is now desepitalized. I don't know how can I do it. Okay, you have already seen it.
Yes,
it doesn't
you
matter.
have done it. Yeah, you have seen it. Yeah.
So just to show you that the amount of tissue that is at the level of the buccal papilla, it's really the minimum you can, because the other tissue is left to give blood supply to the connective tissue graft after desepitalization. And you see that despite such an incredible amount of bone that was covering the implant was also contaminated, and there was no bone at the buccal aspect. If you can show them the cone beam, please. Can you show? Posso avere io la possibilità di comandare il mio cazzo di schermo?
Yes. Giovanni, you have to wait some seconds. So
sorry.
Giovanni, do you correct the implant somehow before you're applying the buccal connective tissue?
Yeah, no, this is before cleaning it. I use some micro brusher to clean the whole implant surface. This is after the removal of the material that was present at the buccal aspect of the implant, but this was not integrated into the implant surface at all. Can I show you the cone beam? Alberto, io so che tu non vuoi mostrare la cone beam.
We want to show your cone beam. Where is your cone beam?
No, se mi dai la possibilità di lavorare nella mia presentazione.
First slide.
Please, first slide.
Yeah,
you can show us your first slide.
Questa?
Yeah.
Ok, scusami.
Yeah.
Look how nice.
Yeah, great. Fantastic.
This is fantastic, in my opinion. You see, there is also a bone peak here. It's incredible. But this did not correspond to the truth.
Yeah.
Silent.
CVCTs is limited. I mean, we all agree with that.
I have the typical question from the audience that many of them will think about. They will ask you, hey, why you didn't put a bone and membrane?
Because the bone did not succeed. And so I decided that it was better to use something else, because somebody before me tried to put some bone there.
So are you putting soft tissue against titanium?
No. Yes. In such a case, I think that the big issue is to be able to decontaminate that amount of implant surface. And so I did my best. I used my titanium microbrusher. I used ADTA, gel chlorhexidine, whatever I have, I can use. But it was very, very limited amount of surface at the buccal aspect. And this amount of surface was covered by the connective tissue graft only. I didn't try to make any amount of bone, or most probably I could have also tried to make some bone of the patient and the connective tissue graft above. But I don't know what is the true difference of this.
Well, audience wants to know about the treatment of implant. Did you treat the surface of the implant? Your implant?
I cleaned it. I cleaned it before.
How do you clean it?
I cleaned it with laser. I cleaned it with burrs. I tried to get rid of as much as that I could see through the cleaning. This was done 2 months prior to the surgery. We clean it, and this is how you looked at it the day of the surgery. So we use laser. I use water lace, YSGG, chromium, erbium, YSGG. It helps. It's not the panacea, but and then antibiotic therapy. We clean the surface with burrs because it's difficult to use the micro brush with such a thin soft tissue. Another thing that really strikes about the case that you did is that every time I see interproximal bone loss, the first thing that I'm thinking is orthodontics.
Yeah, you're right. I agree.
number
I
one.
agree 100%. 100%.
So, and then I'm thinking, well, if I'm going to do orthodontics, in which sequence, in which stage, in which within the time of my treatment, I will do it. And sometimes I use the orthodontist to priorly open spaces to be able for me to graft, or I do the grafting and then I move the teeth around and see what I have in order to overcome the problem. But it's always an extrusion. It's always 3 years treatment. It's not easy.
I think that if I would have done some orthodontic at the end, I would have had the same papilla height you had. That was the only way. That's the only way. But you have to augment the tissue and you have to clean before making any extrusion.
That's correct.
But
Giovanni, there is a question for you. Why, Giovanni, add 2 grafts vertically over each other, and where did you fix the superior one? So if you can explain better, how did you fix the connective tissue graft, and why did you do 2 connective tissue graft on the buccal plate?
No, 1 on the buccal.
1 on the buccal. Okay, and 2
1
on the
buccal and 2
occlusal.
occlusal.
Okay.
Yes. And it was fixed to the connective tissue that comes from the desepithelialization of the papilla, occlusal aspect and buccal aspect.
So when you create the bed, crestally, when you create the bed for the first connective tissue graft,
you see, now we have the bed.
Yes, you have the bed.
Do you see this or not?
Yes, I see.
Yeah, we do.
You create the bed.
This is the occlusal bed.
Yes.
And this is the buccal bed. This is the buccal bed for fixing the graft and also to the periosteum apical. Mm-hmm. And this is the occlusal bed to fix the connective tissue graft to the occlusal aspect, which is the desepithelialized papilla.
Okay, and everything is deepithelialized. So what we see when you suture, everything is deepithelialized on the occlusal one. Okay.
There is also a question for Iñaki. If Giovanni's case would have been your case, in the second surgery, the punch surgery of Giovanni, would you have done the same in the same way? Because you usually make an incision to take advantage of all the available tissue.
For me, this is a no.
Same for me.
I will kill him. If he was my prosthodontist, he would have died a long time ago. No punch.
But Giovanni has always so much tissue; he can share it. He can waste it.
Sometimes
it's not.
1 millimeter makes the difference, So he took so much effort to put it there. You can roll it. You can do many things just to avoid taking it away. I don't like
you. No, Iñaki, you have to understand that these papilla are not supported by bone.
I know.
And so the only way is to leave the papilla height.
Yes.
As they are. And to reach the head of the implant is to remove the tissue that is covering the head of the implant that must be substituted by the crown.
I agree.
But if you do whatever other type of surgery, you open or you don't open, you do whatever you like, you lose papilla height.
Giovanni, you can do tiny crestal incision only to the head of the implant.
Don't advance and apically position the flap?
No.
Nothing.
You apply a little, you open with a tiny incision, you apply pressure to the tissue close to the back. Yeah?
And kept there by the temporary crown there. But when you touch an enormous amount of tissue occlusally, it's not easy. And the big problem of the punch is when the implant is too much buccally displaced that you cannot make the punch, and you have to do exactly what you did. Otherwise, you lose some of the tissue height that you gain in the first surgery. That's absolutely true.
I don't like cover screws. I have.
I like your way of thinking. Because next time, most probably, what I can do is to do my procedure
with less surgeries.
With your abutment. That would be nice.
Yeah, because
your idea to place the graft to place the abutment don't need any punch to be made after, because you have the hole that you can increase progressively with the temporary crown. So you lose less tissue. So it would be nice. That's why it's so nice to discuss, because next time I will ask you to send me your abutment, and I will make the same surgical procedure with your abutment, because it's so thin, it's so small, that it doesn't make any space.
It's easy. You send
I agree.
You send the abutment, 5 millimeter abutment or 7 millimeter high abutment.
The problem is that
you send it to your technician, and with a tungsten disc on a drill, he goes forward, backward, and then you reduce it. You know.
The only thing I think is that you need a bigger graft, because you have to perforate it with the abutment, and so you need a bigger graft than mine. Bigger in terms of dimension, because you create a trauma by perforating it.
Well, the thing is that another issue about the tuberosity and the creeping effect has to do a lot with the phenotype of the patient. We all realize that the thicker tissue we can get from the palate is a thicker phenotype. So in those cases, you have a tissue that will tend to creep more than usual, you know. So it's true that at the beginning I put way too much, you know. We know from the studies that if you go above 3 to 5 millimeters and you plump too much, then you cannot control the growth of that tissue with your crown, you know. But we have learned it. That's why you learned it too. And I think what we know today with the knowledge we have, because you, Giovanni and myself are the only ones that have been relying on soft tissue to increase the aesthetics and the creeping effect. And we have learned that the thicker the phenotype of the patient, the more conservative we are, because we know that that tissue has genetic expression that will tend to grow more, you know. And if you want to grow more, you go more to the tissue. If you want to grow papillas, go to the tuberosity, because you will see a difference than from.
Yeah, because the growth of tissue is very good to have it at the level of the papilla, because this papilla continues to grow and fill the interproximal space, while at the buccal aspect is too much.
Yeah, it's true.
Giovanni, there is a question for you about the reason of the absence of papilla in your case. Will the papilla recess due absence of bone between tooth and implant? The reason?
Obviously, if there is bone, there is no recession of the papilla. That's for sure. You know, so you may, the lack of bone, the lack of attachment at the level of the lateral. I don't know if it was present also before placing the implant, or it was, let's say, a mistake in implant positioning, too much apically positioned. I don't know, but for sure, if there's the intact bone, the papilla don't recede in such a way. It can recede a bit, but not in such a way.
I have a question. I have a really good question for you guys and for the rest of the audience. If we look at the famous 5 millimeter turn-off thing, you know, a lot of people ask me, well, the bone is 9 millimeters away from your papilla. You created a pocket. You build so much soft tissue that you are creating a pocket, and it's impossible to grow 9 millimeters from bone. First of all, the most important of that study is how much you get, what is the percentage you could get with doing nothing at 7 millimeter. This is the most important of that study. And then the other issue is none of the cases that you see on the literature have been grafted with dense connective tissue interproximally and crestally. So for me, the answer is, if the patient can provide you with what you need vertically to graft it there, and you have already 9 millimeters of tuberosity each side, and you have to grow 9 millimeters in the front, now it's a matter of ability, dexterity, because it can be done. This is my
another question for Iñaki.
Yeah, but this is a very important point. Sorry, this is a very important point, because you know, what do you have in such a situation in which there is loss of the peak, but there is the papilla that is good? Something that we can only speculate, and that's why you saw that I apply also some amelogenins. I did root planing, ADTA, amelogenins, in order to try at least to improve the level of attachment, because it was not possible to improve the level of the bone. So this is not a pocket. A pocket is something that you can probe.
Yes.
This is loss of attachment. We are not sure. It's loss of bone for sure. Loss of attachment is not said because let's say that we can also regenerate attachment without bone, at least theoretically and biologically. So it's not a pocket. That's the first thing. The second one is what you can do in alternatives. Because if you remove the implant, yes, can you increase the level of the bone on the lateral by making vertical bone augmentation? Can you do it?
No.
The only way.
So the only thing is to remove also the lateral, or to extrude the lateral, in order to increase the bone peak. That's the only way you can do it. So, the problem most of the time is the alternative. So once you know that you have a patient with let's say, a risky area, because there is an area where there is no support of bone, but there is good tissue, the only thing that you have to do is to put your patient in a maintenance program that for this tooth only, it's much shortened. So it doesn't mean that this patient has to come for the whole mouth cleaning every 2 months, 3 months. But maybe it comes for this to clean this tooth only if it's not good enough, every 2 months, but for this tooth only, because this is a risky area. But if the rest of the patient has no periodontitis, has no problems, it doesn't mean the patient don't come every 2 months for the whole mouth, but just for clean this tooth and to be sure this is perfectly under control. And if the patient is good, you wait 1 more month. If the patient is good, you wait 1 more month. And if the patient is good, you don't wait more than 4 months, no more.
I think
that's my way of thinking.
Yeah. And I think one important issue is the interproximal contacts. Implants are not resistant to periodontal disease, and in some cases, if you don't have interproximal contact, you can have big problems. So prosthetically and tooth movement is a big issue, is a big problem in all our practices, and is something that we have to bear in mind for the longevity of those cases. So I don't know how you control them, but this is maybe
What's your opinion?
Iñaki, these 2 points. These 2 points you guys are raising are very important. Starting with the second one, Iñaki, an open contact point is a local factor for periodontal disease, but as well for caries. And this is what we are seeing, and I think you're referring to it. We're seeing many caries on teeth next to implants because contact points are not assessed properly, as you are saying. And Giovanni, I like very much you stressed that point because I got many comments in social media when they see the final radiographs of both cases, Iñaki and Giovanni, and they say, well, then you have a pocket there. This is not a success because you have a pocket. No, not really. You guys, audience, please, you take a perio probe. You might see the bone very far, but there's attachment. And there's no pocket depth there, more than 4 millimeters. And it's the front area and can be maintained forever. So as Giovanni has stated, plaque control is priority. Maintenance, regular maintenance is also priority, and please do not ensure that we're having a pocket depth just by seeing the radiograph, because we measure pockets by clinically. Iñaki, I don't know if you were referring to local factors on probing depth, periimplantitis onset, and as well as caries on the adjacent teeth on implants.
Well, I haven't seen since I grafted. We did a course, Giovanni and myself, a long time ago in Madrid, just to show how much connective tissue graft can help you as a restorative and periodontist to fix many problems that in other ways it would have been a fiasco, So basically, we have the same message all our lives, how so much that can be done with soft tissue. It's true that it's tricky, it's not easy, but what is easy in dentistry? Nothing.
Yeah. Let me add to this point, Iñaki. You'll be happy probably. We've just had a paper accepted treating periimplantitis by adding a keratinized mucosa by means of free gingival grafts, apically positioned flaps and free gingival grafts on the buccal side and implantoplasty. It's a different story, but we are seeing with those tissues that the stability and the periimplant health is maintained way easier than without connective tissue graft. Yeah.
That's a question for Nart about the slim abutment. you can use this kind of abutment in all the implants, or you can use only in that type of implant that you showed in your presentation?
No. For example, you can use any this concept is it can be adapted to any implant in the world. So basically, the problem is all the healing abutments in the market are designed prosthetically. It doesn't help the surgeon. The biggest problems we face as a surgeon is that the prosthetic connections are way too big. They are in our way. Because what you want is to graft crestally when you have these problems, As a prosthodontist, I want to graft crestally. Location and quality of the tissue is the most important for me. So if you use a conventional healing abutment, it's impossible. Besides that, if you have an implant that is closer to the tooth, then it's impossible to really be able to graft. And then when you close the graft, everything is pushed down in order to have a perfectly flap closure. So having a nail, anybody can close it and have the soft tissue. And besides the nail, the big advantage of the nail compared to the cover screw is that the nail allows you to stabilize the connective tissue buccopalatally. You make a cross, you place it where you want it, and then you close on top of it, And it's one surgery,
Yeah.
And then what you do is you reduce it until you get 2 millimeters, So you create like the base of a champagne cup, to create as much tissue as possible at the connection with your implant,
Yes, people are asking me also about the second connective tissue graft that didn't explain before. We are trying to explain before the presentation of Giovanni. So you can show us the Pajama Technique. Do you remember? We stopped just before.
Here?
So you have to share your screen.
Okay, sure.
Alessandro? Okay, perfect. And so you can left here in the presentation, so you can move your mouse and then your pointer. We can see
here. You see
what to explain. Try to move your pointer.
Do you see?
Yeah, we can see.
Okay.
Yeah.
So basically, so the pajama is, I don't want to take my my abutment off, because if I take my abutment off, I break it, and I don't want to create an incision to have another scar and things like that. I will break it once I'm going to do the provisional restoration. And then I will push it. I don't care about the blanching of the tissue, because all the tissue that I have grafted from is really dense connective tissue, so it won't necrose. It's a totally different approach if you use tissue from the submucosal aspect. You don't have as much. It depends the type of tissue you have grafted from. I will push it one stage, or I will push it slowly. Here, the idea is to have it as thick as possible, so that tissue can just be moved to the emergence profile I have created with my provisional. Why I have to cut it in the middle of the trouser? Because I want to. I'm working from underneath. What you see is how the tissue has been sutured. Before I insert it, the tissue before I get into the tunnel has been already sutured from 4 different sides, so the tissue is pulled from the suturing into the place, and then helped with my spatulas just to bring the tissue exactly to where I am planning. All of this is done before placing the tissue, and tailor it before I place it inside the tunnel.
Okay. Now I think we are okay. After too much of discussion, we can try to conclude our discussion. So, what do you suggest? Which kind of take-home message after this case? What do you suggest to the audience now when we are facing on a case like this, when we are try to explain this, José, Giovanni, and Iñaki? What do you suggest about the case of the treatment of the malpositioning of an implant?
Jose, it's your turn.
Yeah. I think I've learned a lot these 2 days with these 2 masters, and there's a lot of learning that I'm taking, and probably the audience as well. And the first thing I would say is lay back and spend time thinking. I explained very honestly the other day that my first thought was to remove Iñaki's case implant, and I would have committed a huge mistake. So we need to include ortho, and that's probably the main learning issue these days in our strategy. Ortho is key, particularly when we're dealing with papillas and papilla problems. And we've seen also the power of connective tissue grafts. And we knew that, I mean, the 3 of us, this is what we do daily, but we've seen it clearly that it is a must in order to deal with these very difficult cases. But so spending time in the treatment planning, I think Iñaki's sequence is just unbelievable, and it's probably as important as his technically performance. So the sequence is very, very important, involving ortho and then executing. But let's think biologically. I think Giovanni and Iñaki have mentioned many, many things that take you to the disaster, and many, many other things that take you to the success. So coagulum stability, but vascularity, I think, are of key importance. So thank you to you both, because I think it's been fantastic, and the comments are really fantastic for the learning we have experienced.
Well, for me, as an endpoint, what could I suggest to people is to train themselves. Is not about how many implants you put in your career. This can be a tsunami. After 10 years, everything comes back, unless you change your city. Try to do your best. Try to learn from the best. This is not an easy way, but it's the only way you can go to bed and say, well, I did my best and I put all my energy just to provide the best to my patients. And I think this is the most important message you can deliver to all the young dentists in order to be better and to be satisfied with what they do. Thank you.
Yeah, I don't have nothing more to add, because they said everything. I think that this is another proof how the treatment plan, the diagnosis, and the sequence of the different phases it's more important than the surgical technique. But for sure, we have also to discuss a lot about surgical technique, because most of the time in the Congress, we don't have time enough to understand how I manage the papilla, how Iñaki is tunnelized the graft. So we also need to make in this Congress the possibility of the audience to understand a bit more by, let's say, not making battle, but making discussion between the opinion leader of a specific technique, so everybody can understand, and then they can select which technique is more fits much better in their hands. So surgery is very important, and it's something that we have to discuss a lot. We have to understand a lot more, but I think that this was really a very, very important discussion in terms of treatment plan.
Thank you, Jose. Thank you, Iñaki. Thank you, Giovanni, for your discussion. It was really amazing. And so we can say goodbye to all the people that are here, and the audience was bigger. Thousands of people from all over the world are here. We're here. They were waiting for the case of Iñaki, and then there was also the surprise of the case of Giovanni. So it was a big show today. I remember, if you want to see another time this live, you can go on IAO Facebook page or on our website. I remember also that tomorrow, in collaboration with Osteocom, we have also another online discussion between Tiziano Testori, Tommaso Vercellotti, and Antonio Barone. If you want to participate to that discussion, we will wait for you in tomorrow at 4 p.m. on the same Facebook page. So thank you. I bring you also the greetings for the president Alfonso Cagliazzo of the society, and then thank you for attention, and thank you for your time for this beautiful discussion. Goodbye.
Thank you.
Thank you.
Bye bye.
Thank you so much. Thank you. Ciao.
Thank you.
Ciao, 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 ciao.
Ciao.
Ciao, everybody.